Bismillahirrahmanirrahim. Assalamu alaikum and very warm good afternoon. Thank you so much, BICC, for inviting me on this wonderful, exciting, in front of the exciting audience. And it's my first visit to the Bangladesh, and I really impressed with the hospitality that you guys have shown to me. So since morning, I heard that every person who is going to talk, they say that the topic that was assigned to them was very challenging. And you also give me a challenging topic: sequencing of treatment in advanced ovarian cancers in resource limited setup. So first 2 days I was thinking, what should I discuss? What should I tell the audience? So without further delay, I would like to start my presentation. Nothing to disclose. All my expenses and hotel accommodation is being covered by the BIC. So in next 20 minutes, I will be talk about the ovarian cancer. In first couple of minutes, we'll talk about the brief overview of the ovarian cancer. Then we'll discuss the challenges that we, being in a low middle income country, face in the management of the ovarian cancers, and how we can change our practices and how we can do the evidence-based practice in resource-limited setup. So quickly starting, ovarian cancer is the second most gynecological malignancy, and high-grade serous carcinoma is the most common pathology that we encountered. Um, Mostly in our part of the world, patients usually diagnosed at advanced stage, stage 3, 70 to 90%, while stage 4 disease was seen in 90 to 95% of the patients. Median age of diagnosis was 63 years, and 5-year survival is about 49%. What is the global incidence of the ovarian cancer? So globally, ovarian cancers account 18th, rank 18th, and if we look at the mortality, it is about 14. It ranked 14. If you look at the pie chart, the green part, it is the Asia. If you look at the pie chart, from the incidence, from the mortality, from the prevalence, half of the population who has been diagnosed or died of ovarian cancer come from the Asia. Going more precisely in Asia, Southeast Southeast Asia. They are the countries where the ovarian cancer burden is higher. If we talk about specifically low middle income countries, so in Pakistan, Bangladesh, India, Sri Lanka, Nepal, Bhutan, all the countries in South Asia, the ovarian cancer is the fourth most common cancer. So 14 worldwide and the fourth most common cancer among the females in our part of the world. So, what are the challenges that we encounter in low middle income countries? When I was preparing this presentation, I have been gone through an excellent article that was published this year in Elsevier. And in that article, they look at the challenges and opportunities of ovarian cancer care. A qualitative clinical perspective data was collected from 24 low middle income countries. And I'm glad that Bangladesh was a part of that study, and India. So what they highlighted in this study is that lack of the diagnostic facilities and limited treatment centers being the most common challenge that low middle income countries have. So unfortunately, the basic healthcare system in our part of the world is not much as updated and not much as resourceful as it was in the West. So we usually encounter the patients with advanced stage disease. And even though if the patient somehow come to the clinic or come to the hospital due to the poor referral system or due to the lack of knowledge of our GPs, the patient turn into the advanced stages. Impact of cultural norms. In our part of the world, the cultural norms are very different from the West. Women are not think to be or thought to be gone to the gynecological clinics before the age of marriage. Even after the marriage, if the woman goes to the gynecological cancer, it was considered as a taboo in our part of the world. So this is the fact that we have to accept. Inequities in the access of the ovarian cancer treatment. Some part of our region of our country or our area having a good hospital, good resources, but other parts they are deprived. If I talk about the Pakistan, 60% of the population lives in the rural areas where the healthcare facilities are not very much Good. So there is an inequity between the healthcare facility and the most importantly, the poor data collections. So these were all the challenges that low middle income countries or resource limited countries have. And this is basically the physician perspective. It is not the patient perspective. Uh, when we talk about the treatment of the ovarian cancers, we know that ovarian cancer have three major treatment uh, building blocks like the surgery, chemotherapy, or the maintenance therapy. So if we talk about the cytoreductive surgery, it usually costs 3,000 to 10,000 in low middle income countries. That the data is basically taken from India, Pakistan, and Indonesia, which falls under the LMIC. And adjuvant chemotherapy additionally costs 15,000. And when we talk about the use of maintenance therapy, either the PARP inhibitors or the bevacizumab, these are the fancy drugs, and it costs a lot. According to the Pakistan Economic Survey last year, 2024, the average income of Pakistani person is 300 USD. And if we multiply it with 12, like annual income, it is roughly about 3,600 USD. And if you look at the cost of the total treatment of ovarian cancer, it is about 15,000. So 3,600 annual income of a low middle income person versus the 15,000, the cost of the whole treatment. So then we have to think wisely how we can use the things, or how we can use the data or evidence based practice to heal our patients. So that I already discussed that treatment of the ovarian cancers has three major building blocks: the surgery, the chemotherapy, and the maintenance therapy, either in the form of VEGF inhibitors or the PARP inhibitors. So now let's discuss how we, being the part of the low middle income country, can do an evidence-based practice without compromising the survivals and reducing the cost. So we know from the data that for the ovarian cancer, for decades, from since 1975, surgery is the major cornerstone of the treatment. And major cytoreductive surgery, if there is no residual disease, ultimately turns into the improved survival. But there was always a debate that can be giving a neoadjuvant chemotherapy in an upfront setting improve the survival? And this question was answered by the European trial 55791. And this was a randomized phase 3 trial that was conducted in different parts of the Europe, and more than 600 patients were included in this study, and majority of the patients have a stage 3, stage 4 disease. So they were randomized into two arms. One arm received neoadjuvant chemotherapy followed by surgery, and one arm received upfront surgery. So in our part of the world, majority of the patient comes with a stage 3 and a stage 4. The chemotherapy option is relatively cheaper than going for the upfront surgery. And why I'm saying that? Because the medical personnel, the surgeons who are doing the surgeries in our part of the world, majority of them not trained in oncological malignancies, dealing in oncological malignancies. So there are chances of residual disease after doing an upfront surgery for advanced stage disease. And we know from the data, if the residual disease is greater than 1 centimeter, there is high chance of recurrence. So by doing neoadjuvant chemotherapy, can we compromise the survival? The result of this EORTC trial showed that if you can see the bar lines, they are merely overlapping each other. There is no difference. So this trial concludes that patients who underwent neoadjuvant therapy followed by surgery, they have a similar survival, overall survival, without compromising the outcomes. And if you look at the population characteristics, this is not the population characteristics, it is basically the table shows that patient who underwent upfront surgery, 61% patients have more than 10 centimeter tumor, while patients who had received neoadjuvant chemotherapy and then they underwent the surgery, the number before the surgery, before the chemotherapy was about 33%, but it goes down to 24%. There is another trial that was published in Lancet Oncology. This was in a British trial, Chorus trial. This looked basically the same, giving a neoadjuvant chemotherapy prior to the surgery for stage 3, stage 4 patients, and roughly about more than 500 patients were included in this trial. And this trial shows the similar results. So these were the two landmark studies. The CHORUS and the EORTC 55791 trial sets the stage for the neoadjuvant chemotherapy in stage 3, stage 4 ovarian cancers without compromising the survival. The pooled analysis of these two trials were being evaluated for the post-operative morbidity and mortality, and what they found that uh, patients who are getting neoadjuvant chemotherapy, their 30 days post-operative morbidity has been significantly reduced. In the part of the world there, that where we lived, the post-operative morbidity not only impact the patient, but it also impact on the cost of the patient and also impact the pocket of the patient, because if the patient has to stay in a hospital for post-operative complications like dressing, wound debridement, antibiotic, ICU admissions, it will cost a lot. So by wisely doing a neoadjuvant chemotherapy in a stage 3, stage 4 patients, followed by surgery without compromising the overall survival is an alternative option. And mind that this recommendation now is being these interpretations now being recommended by the NCCN guideline and the ASMO guideline as well. Another trial that I'm going to discuss is the ECHO trial, which was last year published in ASCO, which was last year discussed in ASCO. Basically, this was a trial of omitting the lymph node dissection in patients with advanced stage ovarian cancers who have intraoperatively node negative disease. So this was in a study in which patients were randomized to have a retroperitoneal lymph node dissection versus no retroperitoneal lymph node dissections. And majority of the patient in this trials underwent chemotherapy followed by surgery. And out of that, 67%, if I'm not wrong, patients underwent neoadjuvant chemotherapy. 48% of the patients who underwent a retroperitoneal lymph node dissection found to have a lymph nodal metastasis, and only the median number of the lymph node involvement was 3%. When these patients were followed up for the long term, a 9-year follow up, what they found is that whether the patient have lymph nodal dissection or not, their overall survival is similar. But, but keep this thing in mind that patients which are included in this trial have less than 2 centimeter lymph nodal disease on CT or MRI at the beginning, or they have no intraoperative lymph nodes palpable while surgeon is performing the surgery. Another important aspect of this trial is the 30 days mortality. You can see that transfusion-related blood loss, reintervention, urinary injuries were less in patients who didn't underwent retroperitoneal lymph node dissection. So another trial shows that if neoadjuvant chemotherapy or patients with node negative disease, lymph node dissection can be omitted, it not only compromises the survival, but it also reduces the rate of post-operative morbidity and mortality. So these three trials concluded that neoadjuvant chemotherapy can be considered, and Caraco trial showed that surgical de-escalation allowed to significantly reduce the serious post-operative morbidity. Now come to the maintenance therapy. We know that for patients with stage 3, stage 4 ovarian cancer, maintenance therapy is recommended, and it not only improves the progression-free survival, but it translates into the overall survival. So there are the two studies. First, I will talk about the anti-angiogenic agents, the bevacizumab. So there are two studies, GOG 218 and ICON 7. Both the studies look the bevacizumab maintenance therapy. If you look at these trials in a detail, you will find there is a slight difference. Not a slight difference, there is a much difference in terms of the cost, in terms of the number of the cycles, in terms of the dose. In GOG 218 trial, bevacizumab was given 15 milligram per kg every 3 weekly with chemotherapy, followed by 16 additional cycles. While in ICON 7 trial, the dose was 7.5 milligram. Although cross-trial comparison cannot be made, but we being live in a low middle income country can use this ICON 7 trial as in a reduced dose without compromising the survival. Let's look at the data. So ICON 7 is a randomized phase 3 trial, as I already mentioned you. So the patient were randomized into two arms. One arm received the neoadjuvant chemotherapy, followed by interval or debulking surgery after the completion of the chemotherapy, or other arm receive chemotherapy with bevacizumab, which is an anti-angiogenic agent, at a dose of 7.5 milligram per kg every 3 weekly, and this was completed for total of 18 cycle, means 1 year. So it's easier for the residents or the fellows to remember. 7, icon 7, dose is 7.5. So, as I already told you, that cross-trial comparison cannot be made. If you look at the overall population, icon 7 trial showed there was no difference in terms of overall survival. But carefully, if we look at the subgroup analysis, the progression-free survival and overall survival in high-risk patients means those who have a stage 3, stage 4 disease, those patients who have ascites, pleural effusions, they are going to be benefit with the use of the bevacizumab, and you can see the bar lines are very well separated from each other. So you can use the bevacizumab with a lower dose without compromising the overall survival. The next step is the PARP inhibitors, the fancy drugs, can be used to every patient. You know that a majority of the 70% of the patients have an ovarian cancer, had a serious pathology, and half of them have any kind of a mutation, germline mutation, either it's the BRCA, PALB2, BRC1. So you have to check. Any patients with ovarian cancers, you have to check the germline mutation or the somatic mutation. All the guidelines, NCCN, ASCO, SGO, ASMO, all recommends maintenance of PARP inhibitors. Should we consider PARP inhibitor maintenance to all patients in our part of the world? Let's see. Solo 1 was the first randomized trial in which olaparib was given as a maintenance therapy for stage 3, stage 4 patients, and they found the benefit was more in those who have an advanced stage disease, and the dose was 300 milligram BID for 2 years, and it was compared with placebo. In the Solo 1 trial, 99% patients have a germline mutation, and only few patients have a somatic mutations. 5-year follow-up showed that progression-free survival was better. Well, this translates into the overall survival benefit. 7-year data shows that it was numerically significant overall survival survival benefit, but that was not statistically significant. So why this was not statistically significant? Because the data was not mature. We need to follow up the trial population, and patients who are in placebo arm, they may receive PARP inhibitors in the subsequent lines. Paola was another study in which bevacizumab was combined with olaparib for the maintenance therapy. And in this study, patients, the primary endpoint was progression-free survival, and the patients were randomized based on the BRCA mutated or not. So, based on the HRD status. So 47% of the patients have HRD positive, means they have a homologous recombinant deficient status, out of which 29% have BRCA mutation. And about 53% of the patients are HRD negative. If we look at the Paola overall survival in intention to treat populations, initially we can see that graph lines are, Kaplan-Meier curve shows that lines are overlapping each other, but with the time they are separating. If we look at the subgroup analysis, the benefit, if you can see, the lines are very well separated from each other. The population that get a maximum benefit is the HRD positive patients. I think I'm done with the time. I'm quickly wrapping up. So Paola 1 study shows that patients with HRD positive have a more benefit of giving the PARP inhibitor along with bevacizumab. As I mentioned, cross-trial comparison cannot be made, but in the Paola and the Solo trial, there are lots of differences. Yeah, so I'm just wrapping up. So PRIMA is another trial which recently showed that there is no benefit of overall survival or overall survival of PARP inhibitors without checking the BRCA or germline mutation testing. So to conclude, so PARP inhibitors should be used in patients who have germline mutations or those who have a BRCA mutation. HRD positive status. And Solo 1 and the Paola are the trials that mark PFS benefit shown in the patients with HRD or BRCA positive population. So these are the NCCN guidelines. I'm skipping these trials. So how we can overcome the challenges? Just quickly, 1 minute, early diagnosis initiative, capacity building and good referral systems, development of biosimilars, and compassionate access program, buy one, get one free, can help the patient to get these drugs. infrastructural improvements, collaboration with pharmaceuticals to develop a biosimilars. So the take-home message is for locally advanced disease, optimal surgical cytoreduction, platinum-based chemotherapy is the standard of care treatment. Bevacizumab is recommended for stage 3, stage 4 disease. For PARP inhibitors, you either check the germline mutation or check the HRD status. And partnership between the government and the local manufacturers can improve the drug availability and the affordability. I would like to acknowledge Dr. Azmina Tajuddin, Dr. Yasmin, and Dr. Alia Aziz Begum, and my section at Dr. Munira Musaji and Dr. Nadeem Abbasi for encouraging me to go to Dhaka and give this talk. And I would like to thank Mr. Rais Wasi as well. Thank you so much for patient listening.
Thank you very much, Dr. Muhammad Afzal, for your very nice, informative, and very elaborate presentation about the advanced ovarian cancer and the regarding a global